Hello and welcome to the College of American Pathologists live stream and media briefing. We're coming to you live from Las Vegas at the CAP24 annual meeting. My name is Dr. Donald Karcher and I'm president of the CAP. The CAP represents more than 18,000 board-certified pathologists, the physicians who diagnose disease. Pathologists are at the forefront of medicine because effective treatment starts with a correct diagnosis. The CAP also accredits over 8,000 clinical laboratories worldwide, assuring patients and the public that testing performed in a CAP-accredited clinical laboratory meets the highest standards possible. Before we begin, for members of the media and other folks joining us today, please submit any questions for our guests in the chat box or on YouTube during the briefing. If we don't get to your questions because of time, be sure to follow up with the CAP Media Relations team and we will get those questions answered. I believe it's important to begin by discussing what continues to be a huge health concern, the rise in young adults diagnosed with cancer. This is not a blip, it's a real concern. Pathologists everywhere are diagnosing more and more cancers in people under age 50. Here to talk about this are pathologists Dr. Sue Chang and Dr. Jim Jai. Dr. Chang, would you introduce yourself first and then Dr. Jai?
Sure. My name is Sue Chang. I'm a pathologist at City of Hope. I'm based out of Southern California, the Los Angeles area.
Great, welcome. Dr. Jai.
I am Jim Jai. I'm the surgical pathologist, endowed chair and professor. Also, I am the president-elect for College of American Pathologists.
So thank you both for joining us today. Also joining us today are two special guests. Sarah McInerney Hawk, who was diagnosed with breast cancer at age 30, and Elizabeth Waksberg, who at 38 was diagnosed with colon cancer. Thank you both very much for joining us today and welcome. Pathologists have been seeing this rise for a while now. And I'm wondering, Dr. Chang, as a pathologist at the City of Hope, what have you and your colleagues in the laboratory seen when it comes to this increase in young adult cancers?
We've definitely seen an increase in younger people who are diagnosed with cancer, and we classify that as under 50 years of age at the time of diagnosis. And this is outside of things like childhood cancers like leukemias that have been well known. So in terms of colon cancers, breast cancers, there's definitely an increase in the younger patients who are coming through, and also at the age at which they're diagnosed, much younger.
So Dr. Jai, as chair of the pathology department at LSU Shreveport, what has been your experience with these types of diagnoses?
Yes, unfortunately, years ago, when we diagnosed cancer in young adults, we feel kind of surprised. It is not anymore. So we are more sensitive in age, and colon cancer, breast cancer, head and neck cancer, those are on the list, and prostate cancer even are not that uncommon to be seen at patients under 50 years old.
Great, so thanks for getting us started. According to the American Cancer Society, an analysis of global health data suggests that between 2019 and 2030, there will be a 30% jump in early onset cancers. There's no known exact cause for this increase, but there are a variety of possible factors. So Dr. Jai and Dr. Chang, let's discuss some of these factors. Why don't we start with chronic inflammation? How is this impacting this trend?
We know that chronic inflammation, which is defined as sort of a process in the body, releases a lot of different factors inside the body. And there's a lot of interplay between the human body and the environment that we live in. And so one of the big things that we have to answer now that we have this data, and we know it's definitely something to be looking into, is the environment, toxins, what we ingest, what we live in, and how they have an effect on our human body expression.
Yeah, great. Dr. Jai, you want to add anything to that?
I want to give some specific example. For example, inflammatory bowel disease is a known chronic inflammation in the bowel. And then if you don't monitor efficiently, and as time goes on, there is a higher chance to develop cancer, starting from precursor cancer and go on to cancer.
Great, great. So changes in the microbiome. This is the combination of all the microorganisms that are living in our gut. How is this a factor? Who would like to start?
Why don't you go ahead?
Sure. For example, now the processed food, the microplastics, they will change the balance. Normally we have a bunch of bacteria, they formed a balanced environment. When the balance is disturbed, it is easier for the cancer to develop.
Dr. Chang?
There's so much research that's emerging about the interplay between the bacteria in our gut, like Dr. Zhai said, and what the things that we eat and how it affects our health overall.
So here's one that's a surprise to many people. Having children later in life, how is this impacting cancer?
So we know that what we would say, the number of pregnancies and the hormone levels of our patients with uteruses really changes depending on the age at which people have pregnancy or have pregnancy at all. And this is sort of a difference in how our generations have approached reproductive health care.
Mm-hmm. Yeah, Dr. Chai?
Yeah, I agree with Dr. Chen that the age and the number of the babies and has influence, has impact on the cancer development.
Yeah. So Dr. Jai already mentioned ultra-processed foods, and this is one that's come into focus relatively recently. So please, both of you, comment on how this may be impacting cancer in young people.
So we just mentioned microplastics, the kind of new idea, and these things we did not know before. However, this will disturb the microbiome, which is mentioned within the body, within the gut. And once this balance is disrupted, and the immune system can be influenced negatively as well. Once that is negatively influenced, cancer develop relatively easier.
Dr. Chang?
I think what we have to realize is that this is a relatively new development in our human existence, and that we know about its effect now, starting out, means that we can really focus a lot of our attention on this. But I think there's more to come in terms of what we know, the interplay between microplastics and other environmental concerns with our bodies.
Yeah, by the way, I've heard a definition of ultra-processed foods as if it's got ingredients that you can't go to the grocery and pull off the shelf, it's ultra-processed. Like cold cuts are supposed to be a prime example of ultra-processed foods. So this is a biggie, exposure to carcinogens. They're everywhere. These are chemicals that we know cause cancer. You want to comment on that?
So working at a cancer center, I think one of the heartening things about exposure to carcinogens is that young people today are very aware of things like smoking. We've had a great amount of progress when it comes to awareness of I would guess, the older carcinogens, right? The known carcinogens. Rates of cervical cancer have decreased largely in part due to the HPV vaccine, and smoking is down in young people. And so I think that's really heartening to know that public health and public education really does work. So what's next is all the other carcinogens that we maybe don't yet know about and that we really need to look into.
Yeah. Dr. Jai, you want to add something?
Yes, for example, in daily life, too much sunshine. And sometimes we don't think about it, but that is a type of agent or too much exposure. We need to protect ourselves with the sunscreen. Melanoma, squamous cell carcinoma, basal cell carcinoma, other common cancers.
You mentioned microplastics, and this is one that I've read for sure. We are exposed to so much plastic, and it holds our drink and our foods and pretty much everywhere. This is a real concern in terms of being carcinogenic. Finally, healthcare disparities. This is a big issue in our culture. How can you comment about that as a contributor to cancer in young folks?
Here we go.
Go for it.
Sure. So medical access is a very important factor now. I'm living in Shreveport, Louisiana. I see a lot of advanced diseases. Patients with advanced disease could be detected much earlier, and the outcome will be totally different. So the medical awareness and medical education is extremely important. Not every cancer will hurt patients that bad. If you find them early, detect early, and come to be examined, to see a doctor if you don't feel right, that will reduce the chance to develop cancer later.
Yeah. such a change?
It can't be overstated that the needs and the socioeconomic levels of young patients are very different from the patients that we've had at cancer centers in years past. Healthcare access, health insurance, the ability to pay for any of this, you know, as Dr. Zine mentioned, like a lot of patients, a lot of young patients especially, delay going to the doctor because it's choosing between paying back student loans, rent, putting food on the table, and for a lot of young people whose employment may be a little bit spotty, it's really hard to get healthcare insurance. So this is a huge factor that we have to make sure that we think about when we address these kinds of access to care.
Great. So this is clearly a multifactorial problem, and thanks for bringing us through that list. We know that breast, colorectal cancer, melanoma, and head and neck cancers are some of the ones that are rising the most, but many others we know are also rising. So, both Sarah and Elizabeth have shared their journeys on social media. Sarah, please tell everyone a little about your story, including what symptoms you were experiencing, when you were diagnosed, how long it took you to get your breast cancer diagnosis, and where you are in your cancer journey.
I represent myself, but also so many other young adults with cancer. So I first saw my cancer through a dimple in the mirror. I then lifted my arm to do a self-breast exam to realize, okay, there's a lump there. I was young, healthy, and naive and didn't think anything of it. However, I've never really been afraid or hesitant of going to the doctor if something is wrong. Made an appointment with my OBGYN pretty quickly. She did an excellent job of keeping her poker face and telling me that there is something there, but I'm not sure, so we're going to send you on to a breast specialist. I had that appointment about 2 weeks later. Again, went home and was like, okay, who cares? On to the next. I'm young and whatever. And then I did my first mammogram, then was moved on to my first ultrasound. And then I started to realize, oh, wow, this is getting serious when I was asked to sign a paper to have a surgeon I've never met before do a biopsy on me. And so that's when my gut started being like, they're looking for something. I did that, and then I think 48 hours later, I got the results. So I was very thankful to get those pretty quickly. I was told them in a very kind way through the surgeon who did the biopsy, and then the next day had an appointment with my breast surgeon, and the whole thing took off from there.
So thank you, Sarah, for sharing your story with us. So Elizabeth, can you share a little bit about your story? What symptoms you were experiencing, what stage the cancer was when you were first diagnosed, and where things stand currently in your journey?
Sure. I was diagnosed with stage 4 colon cancer on March 14th of 2019. I'd had IBS symptoms for years. I'd gone to GIs starting in my early 20s. I always joked that I was a Desitin and milk of magnesia child. So my dad's a pediatrician, so I had very good relationships with going to the doctor. My sister made a joke about how it was kind of ridiculous because of how often I go to the doctor and how it was missed. I went to several GIs over different abdominal issues, and I was diagnosed first with IBS after they ruled out celiac, and then SIBO. And the first GI that wanted to do a colonoscopy was leaving the network, so my insurance told me to find another doctor. I went and found another doctor, and they looked at me and said I had IBS and bacterial overgrowth. They then said, this is what I think is wrong with you, and I'm never wrong, so this is what's wrong with you. I went to another GI the next year who again offered a colonoscopy to maybe rule out Crohn's or colitis, but they didn't think that that's what I had. And then it was another year after that that I started getting pain up on my left side. I initially felt like I'd pulled a muscle, and I started getting shooting pains, and 2 weeks from the first pain is when I was diagnosed. Actually, by CT scan, I went to a new GI. I met him on the 12th of March, Dr. Sharma, who's with Cedars now, and he ran some blood work, and I had really high inflammation. And so I had a colonoscopy scheduled, but they sent me for a CT, and the CT found that I had a tumor in my colon and spots on my liver. I'm incredibly lucky in that after 3 rounds of chemo, they did a colon and liver resection, and the pathology came back that all of my cancer cells and my tumors were dead. So my official NED date is July 1st of 2019, so I am a little bit over 5 years NED from stage 4 colon cancer.
That's great,
Yeah.
great. Thank you very much for sharing that story. And you've already sort of touched on it, but can Elizabeth first maybe, and then Sarah, share with us about the importance of being your own advocate, listening to your body, listening to your symptoms, and maybe even convincing others that your symptoms are real?
Yeah, I mean, I think that's one of the biggest issues, and you are taught sort of to listen to the doctors and that they understand best. They've gone to school, and I think what we're learning is there's a level of care and treatment, but you are in your body and you understand your body better than anyone else can. And that's why I started the TikTok that I started, which is how I reach younger people. And I have people who comment, I was afraid of a colonoscopy. I was afraid of pushing for a colonoscopy. My doctor said I didn't need one. And I get messages now from people who are saying, I advocated for myself, I pushed for a colonoscopy, I'm 25, they removed precancerous polyps, and they said, you saved my life.
Yeah.
So I'm grateful that learning how to advocate for myself and being able to teach other people how to advocate for themselves is gonna create a wave of finding this earlier if possible.
Great. So Sarah, what advice can you give about listening to symptoms and making sure that others accept that that there's something wrong?
Absolutely. So I want to follow up. I didn't answer fully the first question. I'm currently NED as well as of January 2022. I did bilateral mastectomy, chemotherapy, radiation, and now I'm on hormone treatment to continue to stay cancer-free. So I'm very proud of us, Elizabeth. When I found it, I went right away. I didn't hesitate. I didn't wait for second opinions from friends or anything, like I just handled it right away. And I think taking that action right away was helpful. And of course it was a little scary, but like I said, I was 30, flirty, and thriving, for lack of a better term. I was a marathon runner, absolute lover of kale, and it still happened to me. So like Elizabeth was saying, it's important to remember that cancer does not discriminate. And I had a very fortunate experience. I did everything at Community North Hospital, MD Anderson, here in Indianapolis. And I was listened to and cared for and empathized with from day one. So my advice to everybody is to remember that you are the CEO of your body, and you are also the paying customer. So if you do not like or get what you're looking for as a patient, you are responsible for going elsewhere. And I think I'm a unique case where I stayed in the same place to do every piece of my cancer journey. So I'm very lucky, but I advocated for myself. At one point, I wanted to push back my treatment for some reason, and I was able to do that by having a truthful, honest conversation with a nurse navigator. So you have to stand up for you. It is your life. It's your body. And while you absolutely have to take into consideration a medical professional's opinion and care and thoughts, this is for you at the end of the day. So make sure that you're getting what you need, deserve, and, to survive. You got to feel good about it.
So thank you both for that advice for others, and also congratulations to both of you for being no evidence of disease at this time. So thank you. So this is kind of a follow-up to that last question, but what advice would you give people your age when it comes to going regularly to the doctor and keeping up with cancer screening? Elizabeth, you want to start?
Sure. Yeah, I mean, I think using yourself as an example, to me, again, like my friends go and get colonoscopies because of me. And as if my story can help somebody see the benefit in a colonoscopy, because colonoscopies not only can catch colon cancer, but they can prevent colon cancer. And I think that's the biggest thing, is learning that going for your yearly physical, I write down all my symptoms as I have them, and I, will message my doctor if something new comes up. I probably annoy her, but she's very nice about everything, and she gets back to me because I want to make sure that I'm on top of everything that's happening with my body.
Great, great. Sarah, what do you think?
Yeah, I think it's a little challenging sometimes because I was young, healthy, fit. I don't want people to see my story and get scared and start, freaking out and calling their doctors and getting exams they may not need. So, honestly, my best advice, because most of the time I'm speaking to 30 and under, 40 and under, where cancer is supposed to not be so prevalent. So, my best advice is to build out your family tree and your medical history. And you can do that starting with immediate family, the next generation up of grandparents, great grandparents. That is something that I think we should be responsible for right away, that you can do without freaking out and calling insurance, calling a doctor, and asking for tests that you may not need, because we also don't want, any tests that are unnecessary to happen. So I would start with your family history. I think that's a calm, home approach that you can do now, and then you can learn from that and take that evidence or what you learn and pursue the exams that you need. I will say, when we were younger and in high school and elementary sports, we had to get a physical every year, right? And I think once you stop becoming a participant in school or sports, you stop that. Get your annual physical every year. I don't care how healthy you are, feel, look, whatever it is. My husband is extremely healthy, and after what I went through, he is annual physical every single year, has a primary doctor on call. These are simple things you can do that I would categorize as not over panicking or doing too much, but not being naive or ignorant to the fact that, once again, you are the CEO of your own body.
Yeah, that's a great message for our viewers, for sure. So as pathologists, we know that early detection is key, and that there are several cancers that we can screen for. However, those who are younger sometimes don't meet the age recommendations for those screenings. So, if someone is having symptoms, that should not deter them from getting seen and getting screened. So Dr. Jai, Dr. Chang, can you comment on that?
I absolutely agree that being younger does not exclude the possibility to develop something like cancer later or now. Be sensitive and take care of yourself. Remember, pathologists and are part of the physician treating team, and you can contact us when you have a question about your pathology report or your lab test, and we can explain what it means. Maybe it's a precancer lesion, maybe it's early cancer in situ, maybe invasive carcinoma or metastatic carcinoma, what it means. And we are the expert on those terminologies, and we're there and ready to help.
Dr. Chang?
One of the reasons I'm so grateful that Sarah and Elizabeth are both here today is to help us sort of reach different audiences, right? To expand our knowledge. You know that pathologists are known as the doctor's doctor. So one of the things we're here to talk about is the fact that screening guidelines are guidelines, and they do respond with our increased knowledge. And symptomatology and patient reporting is really the keystone of diagnosis.
Yes, great, thank you. By the way, I know that we are called the doctor's doctor, but I think increasingly we are the patient's doctor. As
Yes.
Dr. Jai mentioned, call us. We want to talk with you, and we can help answer all of your questions. So Sarah and Elizabeth, you've both been very active during your cancer journeys. Sarah, you authored a book. Can you share with our viewers what they can learn from your experience?
Yeah, to wrap it up, cancer is the best and worst thing to ever happen to me. I struggle with that dichotomy all the time, and I've tried to make the most out of it. When I was going through it, dark humor and satire and finding other people with similar situations was the best. Now, since I've kind of graduated into survivorship, I've tried to continue just putting my mental health first, continuing to keep up with my physical health, although it looks very different nowadays than it did back then, which still hurts me a little bit, but I know at the end of the day, I just need to be active to stay healthy. I don't need to be the old Sarah. And with my book, thank you for asking, it's called Does Carcinoma Mean Cancer? It is a graphic memoir about my first 4 days of diagnosis. And this was something I sketched out on a tablet that I have. And then I worked with an artist who's a friend of mine to make it come to life. So it has these beautiful graphics that have a little bit of a double meaning and some art in there to kind of show what it's like when you are going through those first few steps. And so I talk to people diagnosed with breast cancer or who are survivors all the time, and we just immediately speak the same language. And so my book kind of brought some art to that, and it showed people where and what I was thinking in those first few days. And when I received the results before I got the call, I Googled, does carcinoma mean cancer? So that's where the title comes from. And it's been wonderful to continue to make art. And now I'm the executive director of a nonprofit in the breast cancer world. And in a lot of ways, my life has opened up. In a lot of other ways, I face a lot more challenges than I ever saw coming at this age. So best and worst thing that ever happened to me is the best way I can describe
Great.
it.
That sounds great. Elizabeth, I know you work with a nonprofit that helps people get colonoscopies. Can you tell us a little more about that?
Yeah, I would love to. I'm wearing the company, our world class.
Love it.
We like to say world class, emphasis on the ass, since we are colon cancer patients. I met Brooks, who started the nonprofit with our friend Sarah. Brooks and I were online chemo buddies. We were doing chemo around the same time, and we would check in with each other. For anyone who's had oxaliplatin, it is not fun. And being able to speak to somebody who knew what you were going through was super helpful. So she started this nonprofit with Sarah. Sarah is also an NED stage 4 patient. Brooks is an NED stage 3 patient. And what they're trying to do is to push the idea that colonoscopies are part of health and wellness, that it is not a scary word, it is not a scary procedure. I always say that a colonoscopy is way easier than colon cancer. It's also much cheaper. But part of what we were talking about with healthcare disparity is that colonoscopies can sometimes be out of reach for a lot of people. So World Class and what they're doing is they are going to start out funding colonoscopies for people who have a positive stool test but cannot afford the colonoscopy. And the first group that they're starting with are migrant workers in North Carolina, and finding the communities that have the least access to these tests and being able to provide them for them. So worldclassclothing.com, you can purchase t-shirts. I have my bag that says colonoscopy enthusiast, and all of it goes to help funding the idea that colonoscopies can prevent colon cancer, not just diagnose it, and that you can help somebody get a colonoscopy. So they're officially launching on Giving Tuesday, which I believe is December 3rd, but you can purchase now as well.
That's great.
Great.
It's wonderful, and I'm sure you are saving lives through this work that you're doing. So let's take some questions from our live audience. So here's the first question from Dominique. Can you provide more examples? I can't read the rest of the question. Can you provide more examples of known carcinogens? And can people protect themselves from them? So why don't we start with Dr. Chang, some other known carcinogens that people can hopefully avoid?
The classic one is smoking, right? Nicotine and smoking, and this includes vaping. This isn't just cigarette smoking. This is a huge public health concern, and I think this is one that I think is pretty well known, but the different ways that the tobacco industry has changed over the years means that we have to stay vigilant. The other one I touched upon earlier and that the CAP has done a lot of work on is HPV vaccines for cervical cancer and head and neck squamous cell carcinomas. Those are the two that we know about and that are truly preventable causes.
Yeah, great. Dr. Chai.
In daily life, actually, a lot of time you see the exposure to the fine dust. That is a known risk factor for mesothelioma and lung cancer. And be aware of that, wear a mask. We get a chance to expose that, and that will make a difference.
Great. I'll just add plastics to what you both said. It is so ubiquitous in our culture and in our environment. So here's another question. Is there a type, and this is from Jamie, is there a type of cancer in young adults that is most common? So Who wants to start with that one? One that's most common in young adults.
Actually, I am the one of the head and neck pathology expert, and we have seen dramatic increase in head and neck cancer, oropharyngeal squamous cell carcinoma, that is secondary to HPV infection. And as we know, the smoking in this country has declined. However, the incidence of head and neck cancer increased. That is because the HPV infection. So watch out, be aware, and lifestyle, protect yourself. All these are very important.
Dr. Chang, which one do you think is one of the most common?
So diseases, cancers of the digestive tract, so stomach and colorectal carcinomas, truly on the rise, right? And we're talking about men, women, all our patients have a tubular gut, as it were. And so that rate has really gone up. And stomach cancer largely is silent. It's hard to screen for. It's hard to know about. There's a lot of public awareness that needs to happen.
Yeah, great. So those are two examples of really common cancers in young adults that we were not seeing previously. So here's a question from Vicky. Is there data on the prevalence of these cancers by race? How does the prevalence differ by race? So who would like to maybe give some commentary on that? Dr. Chang, you want to start?
Sure. So the data, the most powerful data that we have came out earlier this year and in late 2023. A lot of these are epidemiological, very population-based studies, and that's why they have a lot of power. There's a lot of number behind them. So currently we don't have specific race breakdowns for young people, but one of the generalizations we do know from years and years of cancer research is that African American patients tend to present with worse, higher stage. They tend to have a little more aggressive cancer course, and there are possibly genetic, but definitely systemic issues with cancer care access. And so I think that's one of the things that we want to make sure to turn our lens toward with young people is, does race and access to care have a large impact on the young people's diagnosis?
Dr. Jai, you want to add to that one?
For using head and neck cancer as example, we know that is a gender difference. Males are more prone to cancer compared to women, 3-to-1 ratio. I don't have specific data on that regarding the race.
By race.
Can I interrupt?
Please.
Yes, so in colon cancer specifically, the rise in young people is about 1% to 2% a year, which is a large number of people, but the increase is higher in Black men. So they are seeing that in young people and Black men, and I believe for men, colon cancer, 20 to 40 colon cancer is now the #1 cancer death, and it's #2 for women. Which it overtook lung cancer. But yeah, specifically in colon cancer, Black men are seeing a higher rate.
Great, great. Thank you for adding that. So that's all the time we have for this segment. We'd like to thank, first of all, Sarah McInerney-Hawk and Elizabeth Waksberg for joining us today, sharing your stories with us. And we all wish you nothing but the best going forward. So thank you, Sarah and Elizabeth. Dr. Jai and Dr. Chang, thank you as well for being here. And thank you especially for the work you do every day for your patients. Thanks very much. So earlier at our meeting, I sat down with two pathologists to discuss the idea of dropping the word cancer from some specific diagnoses. Here's that conversation. Please welcome Dr. Kimberly Allison and Dr. Andres Matoso. Dr. Allison, please introduce yourself, and then Dr. Matoso.
My name is Kimberly Allison. I'm the director of breast pathology at Stanford, and I'm involved in CAP through the cancer committee, where we work on reporting standards, and then the biomarkers in breast cancer guidelines.
Great, welcome. Dr. Matoso.
I am Dr. Andres Matoso. I am a professor of pathology, urology, and oncology at Johns Hopkins University, and the division director for urologic pathology at Johns Hopkins Hospital.
So thank you both for being here today. This is such an interesting subject because today cancer diagnoses are often made earlier and cancer in general is better understood. We know concepts like overdiagnosis and overtreatment have entered the discussion, but when a patient receives that cancer diagnosis, do they often choose wisely on how to proceed with treatment? Pathologists do more than just make a diagnosis. So can both of you give us a short background on what sparked this discussion among pathologists and their fellow physicians about dropping the word cancer from certain diagnoses? Dr. Allison, you want to start?
Yes, I mean, I think this is a critical role that pathologists play in society in general. We're really responsible for defining disease entities and re-looking at the criteria and the terminology we're using, because that has a huge impact downstream on our cancer statistics, our mortality statistics, how patients are treated, how we code disease, how we reimburse for disease. That all starts with pathology, and we need to be continually looking at refining and reviving our criteria and our terminology. So I think, has this conversation been around before? Yes, I think it's been in the press. There was a Wall Street Journal article and a Times article in the last couple of years about this topic, about changing terminology, avoiding the word cancer in certain diagnoses that may have different implications for patients than a higher or worse cancer. That's a big bin. Carcinoma has a lot of different types in it. And so I think it's an important conversation for us to keep having, whether or not we decide to change, whether it's terminology or management. We need to have that conversation continually.
Great, thanks. Dr. Matoso.
Yes, so in prostate cancer, this is a discussion that probably started decades ago when it became clear that many patients with prostate cancer would never have any clinical manifestations or would die of the disease. And that led later on to the concept of active surveillance for patients who met certain criteria. And now, once we have a significant experience on active surveillance and with many patients having successfully avoided unnecessary treatment, we are now at the stage where we are discussing should that word of cancer be eliminated in the diagnosis of those patients to alleviate the burden that they feel with that word.
Great, thank you. It seems the diagnosis of certain prostate cancers and breast cancers are what we're talking about. So can you explain, which cancers are we talking about? Let's start with genitourinary.
Yes, so in prostate cancer, there is a grading system that will determine how aggressive the cancer could be. The lowest grade of cancer is called Gleason 6 or grade group 1. If that cancer is composed entirely of this grade, the tumor basically has no risk of spreading at distant sites. And those are the patients that could potentially benefit from a change in the classification of these tumors. And the reason is that this would alleviate anxiety of patients and will probably help them not rush into a therapy that is not necessary and can cause significant side effects.
Great, thank you. Dr. Ellison, which breast cancers are we talking about?
So for breast cancer, we're really talking about the non-invasive, earliest stage, stage 0, ductal carcinoma in situ. So that's pre-cancer, if you will. So it hasn't spread beyond the duct system in the breast. And it can't metastasize. It cannot kill you. So it by definition is a non-lethal. It's not a malignancy. So it's a carcinoma in situ is the current label. And that BIN, DCIS, or ductal carcinoma in situ, has a spectrum of disease within it, from lower grade to higher grade, and that's one of the kind of qualifiers we give in our pathology reports when we make that diagnosis. But there are a number of other factors that influence, whether how aggressive a clinician might be in terms of treating a DCIS, including the size and other risk factors the patient may have. But the conversation is, should either the low end of that spectrum, where it may behave more like a risk lesion than a precancer, should we drop the term carcinoma from that name and label, because we do have entities that are more considered risk lesions that have different names, like atypia. Or should some argue we should actually drop the name carcinoma from the whole group of pre-invasive neoplasia or early cancer.
Great, thank you. I'm going to go back to Dr. Matoso. You had mentioned earlier about active surveillance, that certain prostate cancers appropriately can just have active surveillance instead of surgery or radiation therapy. Can you explain a little more about that?
Yeah, active surveillance is a healthcare approach to a patient who has been diagnosed with prostate cancer with the lowest grade and meeting other certain criteria. And it's based on no aggressive intervention, and this is the main benefit, that the patient would not undergo surgery or radiation therapy. And the goal of it is either avoid it altogether or delay it. And the active surveillance protocols, what they do is they monitor that disease for any signs of progression that could potentially indicate that that tumor could at some point spread outside of the prostate, and then intervene when that situation is presented. And the benefits of that is that the patient would not have the side effects of therapy. However, that being said, many patients decide to abandon active surveillance due to anxiety. Over the years, after being monitored closely, and even though they are not reclassified as higher risk, they decide to undergo surgery and have the side effects of the surgery. And the data shows that that surgery, in most of the cases, does not bring any additional benefits long term for that patient.
Great, thanks for explaining that. So Dr. Allison, what about women with low or intermediate grade breast lesions that are removed during a biopsy? Is that a cancer diagnosis?
Right, so I think you're referring to core biopsies of the breast when someone goes in for a screening mammogram and there's some abnormality found, a biopsy is done, and really you're only getting a small piece of something that might be larger, and the pathologist is trying to make the best diagnosis they can based on that limited sample. But we're only getting a small snapshot, just like for a prostate cancer biopsy or a prostate biopsy. We get a small snapshot, and we don't really know what else is there. So it depends a bit on the size of the original lesion, how predictive it is, what you've got in that biopsy sample, whether you're likely to have something worse left behind. But I think, in contrast to prostate cancer, where we've really come a long way with active surveillance becoming more standard of care, in breast with these really low risk non-malignant lesions like DCIS, even on biopsy, we're just starting to do these trials where we're thinking about doing less. Because currently DCIS, if you are diagnosed with that on a biopsy, you're treated much like a low-grade invasive cancer with surgery, maybe radiation, maybe hormone therapy, just the same treatments that an invasive cancer would get. And so, I think we're trying to understand, can we dial back on some of that? And is the label cancer what's keeping patients from maybe being willing to enroll in trials that look at things like active surveillance? Because we are really in the early stages of making those inquiries.
Yeah. So it's really all about the side effects, potentially avoiding side effects if treatment is not necessary for the breast lesion or the prostate lesion that you've diagnosed, right? That's the concern.
100%. That's
Yes.
the whole point. Yes.
Yeah. So what are the logical arguments, do you think, pro and con, for dropping the word cancer on a pathology report diagnosis? What are the risks? What are the benefits of doing that? Dr. Allison, you want to start with that one?
Sure. So, I think it is something you do need to really carefully consider, and that's why we keep having this conversation. It has major impact on, statistics, right? Epidemiology. What's the incidence of cancer? If you change the name, it's going to drop. If you look for it harder, you're going to see more of it. And so, how does it affect how we're classifying disease in terms of populations? Obviously, the individual wants to know and understand their risk of dying of disease and how aggressive they should be. And I think, the debate about dropping the word cancer gives the benefit of reducing anxiety potentially. I have breast cancer. Is it the same as my neighbor who died of it? No, you've got a very early stage, early, low risk type. Or, can we reframe that and reduce anxiety even more? And so, I think that there's the patient anxiety aspect, there's the population aspect, but I think other risks to think about are, reimbursement aspects. So if it's true that some DCIS does need to be treated aggressively with all those same cancer treatments that an invasive cancer does, are we going to get reimbursement for that? Are the patients going to make the right decision? How do we reset that threshold so that it's meaningful? So it's not without risk, I think, and we do need to carefully consider it.
Dr. Matoso, you want to add to that?
Yes, so I agree there's a lot of challenges related to healthcare. How is it going to be handled in terms of reimbursement and all those things that I think that the medical community could and should work them out appropriately in order to benefit the patients. But if we have an approach that is patient-centered, this is a complex issue that has a lot of benefits that we were talking until now, but also some challenges. In prostate cancer, the challenges that I see are in two different areas. One would be the needle biopsy, which is the initial sampling to make the original diagnosis. That is a sampling that is a small portion of the organ. So then there is a risk of missing a higher grade component and label a patient with non-cancer when in fact it has cancer somewhere else within the gland that has not been sampled. For that, there has been a lot of progress in image studies, MRIs that are more precise in detecting higher grade cancer, and it has improved, and we now have a 15% improvement of detection of lesions that otherwise would have been missed, and they are of higher grade. So there has to be some more work in that area. Maybe biomarkers that could separate tumors that are truly indolent from those who are going to temporarily progress, because another heterogeneity within these tumors is that they could be a grade 1 this year but progress to a grade 2 or 3 in the subsequent years. So for that, there's some work being done in different biomarkers that could, besides what we look at the microscope, determine that this tumor has a higher potential to be more aggressive next year. And then finally, something that is very important among pathologists is the reproducibility of grading. Anatomic pathology diagnosis is somehow subjective. We follow a lot of rules on how to proceed and grade, but there is a human subjectivity component. In that regard, I think there has been significant improvement with the incorporation of artificial intelligence within this field, in which tumors that are borderline between grade 1 and grade 2 it could be potentially that subjectivity decreased with the use of artificial intelligence. Because one of the things that scares the most the pathology community would be with this poor reproducibility, one patient might get a non-cancer diagnosis from one pathologist, and that same sample go to another pathologist, and that patient will get a second diagnosis that is cancer. And that would create a lot of confusion.
So as you both said, this is a complex issue. It's really balancing patient anxiety, unnecessary side effects that we want to avoid, and maybe we need even a little more science to really come to the right answer. And you mentioned already a tool that we're all talking about, can AI help us in making these diagnoses, hitting the right set point between not necessary treatment or necessary treatment. So is there anything else that you'd like to add, something that you want to leave, something important for our viewers that they should need to know about this discussion? Possibly thinking about what must happen before changes are made. Dr. Allison, you want to start?
Yeah, I think the message is, it's not simple. We're carefully considering things. We take it seriously when there's a cancer diagnosis. And what do we need? I agree with Andreas, Dr. Matoso, that we need more tools to help us better stratify risk, help us be more reproducible at thresholds. And then, really it's communication, right? In the end, what we're communicating in our pathology report, it's a message to a patient, it's a message to their clinician that, this got the cancer label, this one didn't. And inevitably, you're going to have gray zones right at that threshold. And us as pathologists need to use those diagnostic criteria to the best of our abilities, use tools that are available to us, like a second opinion, from a colleague even, just to make sure, when you're in that gray zone, I'm going to fall on this side of the fence versus the other. I think it's important for clinicians and patients to understand that, and for us to communicate in our report, this one was close to a threshold. We opted to call it cancer or not, but knowing that, might change the conversation in the management decision.
Great, thanks. Dr. Matoso, anything to leave for our viewers that you'd like
Yes,
them
I would
to
say
think
that we have come a long way in the interpretation of these patients with clinically insignificant prostate cancer. When I first started to practice medicine, this was a new concept, and the adherence to these protocols of active surveillance was as somewhere around 10% of the patients who would qualify to it. We have now around 60%, and it varies in different regions of the country, and mostly based on cultural concepts of the word cancer. So with all these years, maybe 20 years of experience in this field, we have gained a lot of confidence that certain patients will never need treatment. And to those patients now, we owe them a new nomination so that they don't bear this socially burdened diagnosis of cancer when no treatment is going to be done about it. So I think it's a process. It would take more time and more information and more tools to bring a sense of safety in doing so.
Great. This has been great. Thank you both for everything that you've shared with us today. So communication with your healthcare team is always a critical part of any cancer patient's journey. Welcome back to our live media briefing. We can't mention the next topic enough: viral threats, not only here in the United States, but around the world. Joining us in the studio today is Dr. Christina Wojowoda. Dr. David Schwartz joins us from Atlanta, and from Omaha, Nebraska, Dr. Teresa Austin Carr. Welcome to all three of you. Please introduce yourselves to our audience. We'll start with Dr. Wojowoda.
Sure, I'm Christy Wojowoda. I'm a pathologist and I specialize in clinical microbiology. I'm at the University of Vermont Medical Center, and I'm a professor in the Larner College of Medicine.
Great, thank you and welcome. Dr. Schwartz.
Hi, my name is Dave Schwartz. I'm in Atlanta. I am a perinatal, placental, and obstetrical pathologist. I'm also an infectious disease pathologist. And in addition, I'm a medical epidemiologist, and I work in the area of global maternal and infant health.
Great, thank you. And Dr. Carr.
Hi, I'm Dr. Tess Carr. I'm a fellow of the College of American Pathologists and a member of the CAP Microbiology Committee. I'm also an associate professor and the director of the Clinical Microbiology Laboratory at the University of Nebraska Medical Center.
Great, thank you all for joining us. So let's begin with an emerging viral infection. First, Oropouche virus. This is a word that many of us are just hearing recently for the first time. Dr. Schwartz, can you give us a brief explanation of Oropouche, where it's being found, how it spreads, and who it affects?
Certainly. Thank you, Dr. Karcher. Yes, the Oropouche virus has been around for a long time, but it has recently emerged as a public health threat, primarily starting off in Brazil, essentially in rural areas, in the jungle, so to speak. But it has spread rapidly throughout parts of Brazil into adjacent countries in Latin America where it never existed before. And then importantly, it has also gone to Cuba. It's an insect-borne virus, what we call an arbovirus. It's transmitted by little biting midges that are called culicoides. And the virus itself is now affecting many, many thousands of people, again, primarily in Latin America. But we've also seen spread of the virus outside of these regions via travel, essentially airline travel, from infected passengers. And we've got 90 cases reported in the United States, primarily in Florida. And that's the relationship, obviously, between residents of Florida and Cuba. But it's also been imported into the European Union. What's striking about Oroposh virus is the fact that in Brazil, they are reporting poor obstetrical outcomes from it. And these include stillborn babies. And because the virus is neuroinvasive, they are also reporting babies that have abnormally small heads, what we call microcephaly, associated with pregnant women who had the infection during pregnancy. And so this combination of pregnant women with the infection losing their babies prior to delivery and then having malformed babies after delivery is very reminiscent of another virus that we had experience with several years ago, which is the Zika virus, another insect-borne virus, but it's a different type of virus. Fortunately, in the past couple weeks, there have been very few, if any, Oroposh viruses reported from the endemic areas. So this appears to have quieted down somewhat.
Great. Thanks for giving us a quick rundown on that virus. Now, here's one that we have been hearing a lot about, Mpox, or monkeypox, what we used to call monkeypox. So can you tell us where that virus is, where is it spreading, and is this one also a toll on pregnant women?
Well, thank you. Again, Mpox, formerly termed monkeypox, is the most dangerous member of the poxvirus family, the Poxviridae. Remember, we eliminated smallpox, thank goodness, back in the 1980s. But Mpox has been endemic in Central and West Africa for decades, if not longer, and primarily the Congo, the Democratic Republic of the Congo. As you know, a few years ago, we had a global Mpox outbreak that primarily affected men who have sex with men, including here in the United States, Europe, and elsewhere. And that was due to a specific strain of the virus that we call the Clade 2 strain. Unfortunately, now in DR Congo, we're having a new outbreak of a newly described clade of the virus called Clade 1b that is not only genetically different, but seems to have increased virulence or pathogenicity. And unfortunately, again, we are getting reports from DR Congo that 50% or more of pregnant women who are infected with the virus are losing their babies. This is an extremely high case fatality rate for fetuses in pregnancy. It starts to approach things like hemorrhagic fevers, like Lassa fever, and even Ebola virus. Fortunately, we have a vaccine for monkeypox, and this is now being distributed in the DR Congo and adjacent countries where this virus is spreading.
Great. Thank you for filling us in on the latest on that and the
Sure.
scary new Clade 1b for sure. So you've worked as a global epidemiologist. Do you think there will be another epidemic like we saw with COVID?
Oh, absolutely. I'm on a World Health Organization committee where we are planning our response for the next pandemic, particularly in pregnant women, the fetus, and their babies. Sure, this is really how nature works. There's a lot of viruses out there. the environment changes, we have global warming, we have changes in agricultural practice. These changes in the environment and in viral genetics themselves create risk factors for emerging viruses to come into human populations. And so I think the answer is yes. It's just a question of what and where they will be, which is why it's so important that the public health community and the medical community be prepared for them.
Yeah, great. It's really not a question of if, it's really when. And it's very encouraging to hear that WHO and others are working to prepare us. So, Dr. Wojwoda, we've seen an outbreak recently in Eastern equine encephalitis virus, or EEE. What is it? Is this something that our viewers should be concerned about?
So Eastern equine encephalitis virus, so you'll hear it called EEE, is another one of those arboviruses that Dr. Schwartz was talking about. So we get it from the bite of a mosquito. It's seen mainly in northern and eastern states. The good news is most people who get infected with EEE don't even know that they had it. They have no symptoms at all. Those that do get symptoms, the majority just have some mild symptoms: fever, headache, body aches, kind of tired. The scary part is that less than 5% of people that get infected will have severe symptoms. So bad headache, neck stiffness, seizures even. And of those less than 5%, 30% can die. The people that survive that infection, those severe symptoms, half of them will be left with severe problems like seizures, mental impairment, paralysis. So good news, it's pretty rare. There have only been 16 cases reported to CDC as of this year. But the bad news is if you get that severe disease, it can be pretty impactful. The other good news is it's pretty easy to prevent. So while we don't have a vaccine for it, you can wear long sleeves, long pants, wear insect repellent, or if you're really worried, stay indoors dawn and dusk when the mosquitoes are out. But I think in general, most people don't need to be worried about it. And right now it's really focused in the Northeast.
Great, thank you. Thanks for filling us in on that. So Dr. Carr and Dr. Wojwoda, I know we're all COVID, flu, and RSV weary, but these viruses are very much with us and will again become a major problem for folks in the United States this fall and winter. So what are you both seeing at your institutions when it comes to these viruses, and can we expect surges in the upcoming season?
So in Vermont, we're still seeing some COVID, but it's decreasing. Flu and RSV are very low for us right now, so it's kind of a lull period. Go out and party, I don't know, things aren't so bad right now. We are seeing a lot of rhinovirus, common cold, and so if you do have respiratory symptoms, it could just be a common cold virus. In terms of surges, I won't predict anything anymore. I was wrong every time I made a prediction with COVID, but everyone can do their part by getting their vaccinations, staying home if they're sick, wearing a mask if they're sick.
Great. Dr. Carr, what are you seeing in terms of these viruses?
Well, the good news is that we're seeing a decrease in COVID infections, and as well as a decrease in markers of severity, such as hospitalizations and deaths due to COVID in the last several weeks. Also, we have not yet begun to see many cases of flu or RSV this season. With that said, we can anticipate a surge in respiratory infections this fall and winter, just like in most years. And while we can't predict the exact timing or severity of this, if previous years have been any indication, we would expect it to come sometime around the end of October, beginning of November, and potentially last until April or May. So that's the usual pattern.
Great, thank you very much. So here's an opportunity to remind our viewers, like we do each year at this time, the importance of testing and tracking your symptoms. Dr. Wojwoda mentioned rhinovirus. It can look a bit like these other viral illnesses. We know that people are now familiar with at-home tests. So what about the importance of treating those tests with respect in order to get the right results? Dr. Wojwoda, you want to start with that one?
Sure. So those tests have been great. They've helped a lot of people diagnose if they're ill or not with COVID. But you really got to follow the instructions. We are very strict in the laboratory and follow every single instruction right to the letter, and you should do the same if you're doing a test at home. The other thing to keep in mind is the expiration date of the test. You want to make sure that your test has not expired. But if it looks like your test expired, please go take a look at the FDA website. Some of the expiration dates have been extended, and so you still might be able to use that test. Recently, they're coming out with tests that not only test for COVID, but also flu and RSV. I would steer clear of those tests. I don't think they're worth the money. You could never test at home for all of the viruses you could possibly be infected with, and I think they give people a false sense of security. So the real point is, if you're ill, you stay home until your fever is gone for 24 hours without any medication, and you wear a mask if you have to go out while you still have symptoms.
Great, thank you. Dr. Carr, do you want to add anything to that about the at-home tests?
Yeah, so like Dr. Wujawoda, I would also like to stress that it's very important to follow the instructions exactly as written, because even though these seem like simple tests, there are a lot of opportunities for error. So when we run a test in the lab, we have to follow the instructions to a T in order to say with confidence that the results we're giving are accurate. So we can't change up the sample type or the steps we follow without doing a lot of behind the scenes work to make sure that those changes don't impact the test in a negative way. And those same rules apply to a home test. So if it says swab your nose, don't swab your throat, follow the steps exactly as they say to do on the test. And also, I'd like to stress that if you get a negative test, you do need to do a second test a day or two later. So the home tests say right in the instructions that you need to perform a second test a day or two later, because these tests just aren't as sensitive as tests we perform in the lab.
Great, that's great advice for folks listening about these at-home tests. So, Dr. Carr, there are several COVID subvariants. This is something we got very used to all through our time with COVID-19. Is there one that's rising to the top, and are these subvariants potentially stronger or more severe?
So the strain that has become a concern over the last several weeks is one you may have heard about, the XEC variant. And this is a new variant that's actually a recombinant mixture of variants, which are related to the Omicron viruses that we've already been vaccinating against. Now, the good news is that this new strain does not appear to cause more severe disease than other strains. But what's different and concerning about it is the speed at which it can move through populations. So we do expect to see more transmission within the community. And one thing you might be wondering about is whether the updated vaccines will cover this new variant. And while it is a new virus, there may be some additional immune escape with this new variant. The most recent vaccines target closely related strains, so we would expect some degree of immune protection with the updated vaccines. So I would encourage everyone to get your booster just as soon as you can.
Great. So we know that we've seen a drop-off in vaccinations recently for flu, for COVID, for RSV. So any one of our panelists, please comment on remind us all of the importance of staying up to date with vaccination. Dr. Wujawoda, you want to start?
Sure. So everybody this fall should be getting a flu and COVID shot. Remember, we have to keep getting vaccinated annually to increase our immune protection. We got to remind our body what these viruses look like so they're ready to produce antibodies if we get infected. RSV, pregnant patients and elderly patients should be getting vaccinated for RSV, but that's really a conversation with your provider. There's a little bit of nuance of who should get that vaccine and when. Yeah, everybody really needs to do their part, and we have to remember that getting vaccinated doesn't keep us from getting sick altogether. That would be great, but that's not what these vaccines do. They keep us from getting really sick and having to go to the hospital.
Great advice. Dr. Carr, you want to add anything to that about reminding people about vaccination?
Yeah, so getting vaccinated for COVID and flu is important for two main reasons. First, the immune protection, as Dr. Wujawoda mentioned, that we get from either the vaccine or natural infection begins to decrease with time. And we know that the best protection is within the first 2 to 3 months following the vaccine. So timing is important. That's why we get our updated vaccines in the fall before flu season. Second, both influenza and COVID-19 vaccines are updated to give you the best protection from the currently circulating strains. And the better matched these are to the circulating strains, the better protection you get. And while we know that the most recent flu and COVID vaccines aren't perfectly matched to the current strains, they both still offer a significant degree of protection. The influenza vaccines typically will give anywhere from 25 to 45% protection against illness that requires medical attention. And there was a recent South American study that looked at the impact of this year's flu vaccine, and that found a 35% reduction in hospitalization, which may not sound that great. It's not as effective as last year's, which was about 50%. But I would still say that, with a 1/3 reduction in hospitalization risk is very impactful and definitely worth doing.
Great, thanks very much. So, Dr. Schwartz, last year the FDA approved the first RSV vaccine for pregnant women. Do you recommend that pregnant women get this vaccine?
Well, that's a very good question, Dr. Karcher. I think it's very important for pregnant women to consider a number of vaccines during pregnancy, because we know that certain vaccines will not only protect mom, but they can be life-saving for the fetus and the newborn. And certainly the new RSV vaccine, Abrysvo, that was approved last year, appears to be one of these. It's given between 32 and 36 and 6/7 weeks of gestation. It can't be given later than that because mom's body needs to have time to develop antibodies that will pass from the placenta into the fetus. And then we have found that following delivery, those antibodies provide significant protection to the newborn against RSV virus, reducing risk of hospitalization almost 70% 3 months after delivery, and also reducing potential severe disease in the baby. So I think, in consultation with a pregnant woman's obstetrician or other healthcare provider, that they should certainly consider getting an RSV vaccine. But in addition, I think, as Dr. Wojewodo mentioned, the influenza vaccine is especially important in pregnant women because influenza can do really bad things to mom when she's pregnant. And we know this from previous influenza outbreaks. And perhaps most of all, if I can just mention it, the COVID-19 vaccine is very, very important for pregnant women to get. My colleagues and I reported a few years ago, actually in our journal, the Archives of Pathology and Laboratory Medicine, that fetal deaths and stillbirths were occurring primarily in non-vaccinated women. And in those women, the virus was causing 75% or more placental destruction, which of course resulted in fetal demise. And we also reported that the COVID vaccine seems to be protective against stillbirth and neonatal death in infected women. So these things have not changed. Fortunately, there is so much immunity in the community to COVID-19 right now, based on a combination of naturally occurring infections in the community and vaccination, that the rate of placental infection with SARS-CoV-2, which is the COVID virus, has dropped dramatically. And amongst my colleagues and myself and my network, we're just not, thank goodness, seeing stillbirths related to COVID-19 at this point in pregnant women.
So that's all great advice. Obviously, all three of these vaccines are important for pregnant women, as well as the other members of the population that we discussed. So let's take some questions now from our viewing audience. And here's the first question. are there particular regions or communities in the U.S. that are higher risk for these viral threats? Who would like to start with that? Dr. Wojciechowski, you're sitting to my right, so why don't you start?
Areas where, as we've discussed with mosquitoes, often have higher chance for viral threats. In addition, large cities with large airports where people are flying in from other countries and bringing with them either mosquitoes or infections often can be landing places for these new infections.
Yeah, Dr. Schwartz, you mentioned Oropouche I guess, in the southern parts of the United States. Is that true? That's where the danger is?
That's right. It's primarily in Florida, as these cases are imported from Cuba. But I would like to, if I could, just respond to your question.
Please.
And in terms of geographic and regional variation in viral prevalence, at least in the United States, if you look at a map of vaccinations across the country for any given infection, you'll see that there are significant geographic differences. Here in Georgia, we see it between the cities and the rural counties, with rural counties in general being significantly less vaccinated against everything than we would in places like Atlanta or Savannah. I'm sure you see that in other states as well. And that can create a discrepancy in risk within the community for acquiring whatever viruses are currently spreading. It's very important, when COVID vaccines came out, back a few years ago, we had counties here in Georgia that were showing 15% vaccination rates. And these counties were the most affected with COVID-19. So I think that to a certain extent, this is an educational issue where maybe we haven't done the best job in public health that we could for educating people as to the importance of vaccines. But obviously, there's other cofactors at play as well.
Great. So let's go to the next question. How can individuals stay informed about emerging viral threats and the latest guidance from health professionals? Maybe Dr. Carr, you could start with that one.
Yeah, so that's a great question. The sources of information that I rely heavily upon are the CDC website that generally provides very up-to-date information about the latest recommendations as well as what is circulating currently. For more local information, you could turn to your local or state public health websites. These are a wealth of information for anything from testing recommendations to treatment recommendations to information about what's circulating in your community.
Great, thanks very much. Thanks for all three of you. So our time's up for this segment. I want to thank all of you for being here today, providing us with such valuable information. If you're interested in talking with any of our panelists, please contact our media relations staff. Their contact information will be on the closing slide. So we hope we've enlightened you and provided some insight into exactly what we pathologists do and our extensive reach across all of medicine. A recording of this media briefing will be available shortly at cap.newsroom.org. On behalf of the College of American Pathologists and our members, I'm Dr. Donald Karcher, and I want to thank you for joining us today.